Om Swastiastu. Hello, we're from SGD 1, and on this opportunity, we're about to presentate our student project about multiple myeloma. Next. This is our team members. Next. My name is Chokuda Sinta Namaskawati with 3-digit of student number 231, and I'm going to explain about the background. So multiple myeloma is a rare disease, including the second most common hematologic malignancy after lymphoma. And the estimated worldwide 5-year prevalence is approximately 230,000 patients, with the median age at onset around 66 until 70 years old, and some of them being younger than 65 years, and only 2% of patients being younger than 40 years old. It was observed and appears to occur more frequently in men, and this malignancy is not considered as a genetic disease, but sometimes in familial cases can occur. Next. Multiple myeloma evolves from a premalignant condition clinically recognized as MGUS, or monoclonal gammopathy of undetermined significance, which is usually asymptomatic and detected mostly on laboratory findings. And for the treatment, it is getting improving in the past decades due to the availability of effective therapy with the use of autologous stem cell transplantation, or ASCT, followed by novel treatments such as proteasome inhibitor and immunomodulatory drugs. Next.
I am Vicky Samantha with the last 3 digits of student number 079. So these are the problem identification of her paper, and the purpose are to know the importance to understand the definition, cause, types, pathophysiology, symptoms, and prognosis of multiple myeloma, as well as how to diagnose and treat it. And after understanding the definition, etiology, types, pathophysiology, symptoms, treatment, and prognosis of multiple myeloma written in this paper, we hope the clinician will be able to know how to manage and give effective treatments to patients with multiple myeloma.
Okay, my name is Christian Bastiantalo, number 075. For the definition, multiple myeloma is a neoplastic plasma disorder that is indicated by clonal proliferation of malignant plasma cells inside bone marrow, monoclonal protein in the blood or urine, and associated organ dysfunction.
Good afternoon, my name is Bellatrix Agus Saraswati, number 152. Etiology of multiple myeloma. The cause of multiple myeloma is not clear until now. The genetic mutation is suspected to be the cause. Normal plasma cells will produce antibodies to protect the body, namely M protein. However, when these plasma cells become myeloma, the antibodies produced do not function properly. This will cause M protein to accumulate and damage the body's organs. Multiple myeloma is often associated with MGUS, or monoclonal gammopathy of undetermined significance, because 1 in 100 people with this disease will develop into multiple myeloma. There are several other factors that can increase the risk of multiple myeloma, such as elderly, exposure to high levels of radiation or low but in a long time, family history of this disease, obesity, and history of plasma cells disease or other cancers.
My name is Rosabel Eugene Priatna with student number 115. So for the epidemiology, multiple myeloma prevalence in the United States is about 5 per 100,000, and it is affecting men 1.5 times more than women. This indicates that sex have an effect on the onset of the disease. Meanwhile, in Indonesia, the prevalence of multiple myeloma is not yet clearly known. Cancer registrations of Dermais National Central Hospital data shows that incidence of multiple myeloma in Indonesia from year 2005 to 2007 was 0.23 per 100,000 population. Meanwhile, in Sangal Hospital or FK Unud, the prevalence of multiple myeloma in year 2013 to 2017 was 24 cases, with the most cases is in 2017. Thank you.
Hello doctor, hello my friend, my name is Nara Sarapausi, student number 135. So I'd like to tell you the type of multiple myeloma. They are divided into 2 types, which is differentiated by the symptoms. The first one is smoldering or asymptomatic, where the smoldering multiple myeloma is a precursor stage of multiple myeloma. And the second one is active or symptomatic multiple myeloma, where there is abnormality in the plasma cell in the bone marrow. Those 2 types can be differentiated by National Comprehensive Cancer Network or NCCN criteria.
Hello, my name is Timothy Kurnia with NIM 006. So now I'm going to explain about the pathophysiology of multiple myeloma. So multiple myeloma have three steps of pathophysiology. The first one is going to be MGUS, or monoclonal gammopathy of undetermined significance. So MGUS is distinguished from because its protein MGUS monoclonal M spike is below 30 grams per liter and is not accompanied by damaged organs, and it also have plasma cells in the bone marrow below 10%. While smoldering multiple myeloma, or SMM, is the second stage, or it is the development of MGUS. It has the M spike above 30 grams per liter and the plasma bone marrow above 10%, but it doesn't have the end organ damage. And finally, it will progress and then it will end up being multiple myeloma, or MM, and which is characterized by M spike above 30 grams per liter, the plasma cells in bone marrow above 10%, and it is followed by an end organ damage. And the end organ damage to MM is also known as CRAB. It is the acronym of calcium, renal, anemia, and bone. Next. So now the next one is going to be the pathogenesis of multiple myeloma in general. So in this picture, the orange round cell indicate normal B lymphocytes, while the yellow round cells are the post-GCB lymphocytes, which have undergone a later mutation and differentiate into long-lived PC, or plasma cell. In the pathogenesis of MM, or multiple myeloma, an initial genetic event, or the red rectangle, occurs in the germinal center, or GC, and it is facilitated by the somatic hypermutation and isotype switching processes, which are found in the cell groups that will become multiple myeloma itself. There's a further genetic mutation, and it is marked by a red circle with a new mutation encountered during the disease evolution. And it is done heterogeneously in subclones, especially in the S1 and the S2. Okay, next.
Hello, my name is Putri Agnes Monica with the last number student 100. So let me explain about the bone pathophysiology of bone lesion in multiple myeloma. We know bone lesion in multiple myeloma is the important sign that can decrease of the quality life of the patient and also increase the number of mortality and the morbidity. So the basic pathophysiology of bone lesion in multiple myeloma is uncoupling process of the bone remodeling. Where it occurs because of the interaction between myeloma cell and the microenvironment of the bone marrow can cause the increase of the osteoclast activity and decrease of the osteoblast activity. Increase the osteoclast activity because of the osteoprogretin decrease, so the RANG ligand and RANG receptor can bind and produce more active osteoclast. And why of the osteoblast activity decrease? Because of the decrease of interleukin 3 and interleukin 7 that can inhibit of the differentiation of the osteoblast.
Good afternoon. My name is Claudia Felicia Limanda with the number 19025111058. So today I will explain about the symptom of the multiple myeloma. The first symptom is the bone pain. It is mainly in the back, hips, and skull, and then there is bone weakness and broken bones. The broken bones can be so extensive that it can lead to the osteoporosis, and then there is constipation, loss of appetite, and excessive thirst that can lead into weight loss. There is nausea and confusion as well as the symptoms from the nervous system, and there is the symptoms from the immune system such as the decrease of the immune system and can lead to extensive infections. Next, I will explain about the diagnosis of the multiple myeloma. So in diagnosing a multiple myeloma, there is no single test that may rule it out. The first test is to do an anamnesis and to do a physical examination well, and then we can add with a biopsy test of the plasma tumor or counting at least 10% of the bone marrow cells. And we can add one of the following. We can count 3 grams of per deciliter of M protein in the blood, or 1 gram per deciliter of the M protein in the urine, or do an imaging studies of the tumor growth. Thank you.
My name is Brian Gervais, last digit number 053. Treatments for multiple myeloma can be divided into 2 types. Non-intensive, which are aimed at older patients, and intensive, which are aimed at younger patients. Non-intensive treatments are often recommended for most cases, although both of them involve using a combination of anti-myeloma medications. Intensive treatments involve the usage of higher dose and is followed by extensive stem cell transplant procedure. The medicine generally includes a chemotherapy medicine, steroid medicines, and either thalidomide or bortezomib. Thalidomide is most often used. It is believed to work with a mechanism by slowing down the blood vessel growth around the abnormal plasma cells. It is an anti-angiogenesis medication. This helps reduce the nutrients that the plasma cells present, which are needed to grow. It also helps to the body immune system to fight the multiple myeloma. The dose are usually 50 until 200 milligrams and is often used along with steroids. Although thalidomide can cause birth defects, it should not be taken by pregnant women. Common side effects include chronic constipation, drowsiness, numbness, and dizziness. In the next slide, we can see that there are other medications which can be used. Those are the medications and the doses and the route and the schedule.
Hello, my name is Bagusan Kastia with 3 last digit studio number 032. Survival rate of patient with multiple myeloma depends on the disease stage. Although, theoretically, the median survival is approximately 3 years. Some patients with multiple myeloma can live longer than 10 years. Prognosis of multiple myeloma can be reviewed by monitoring the SGD1 molecule. SGD1, transmembrane type 1 heparan sulfate proteoglycan, is found on the surface of the most myeloma cells, whether in the bone marrow or in the blood. The numbers are likely to underestimate the current survival rates, as the number predate the arrival of monoclonal antibodies and some new agents that have been released in the last 3 to 5 years since then. Thank you.
Hello, my name is Widya Harawati with last 3 student number 175. So the conclusion of our student project is multiple myeloma is a neoplastic plasma disorder that is indicated by clonal proliferation of malignant plasma cell inside the bone marrow, which can lead to some hematological malignancies such as lymphoma, leukemia, anemia, bone pain, and fracture, with the number of cases in Sanglo Hospital FK Unud in 2013 until 2017 reached 24 cases. The etiology of myeloma is still not clear, but the genetic mutation is suspected to be the cause and often associated with MGUS or monoclonal gammopathy of undetermined significance. Based on the National Comprehensive Cancer Network, myeloma was divided into 2 types, smoldering and active, and the pathophysiological aspect of myeloma was started with MGUS, continued with SMM or smoldering multiple myeloma, and ended by SMM process to MM. Bone pain was the main symptom of multiple myeloma, which often occur in the back, hip, and skull, which may lead to bone fracture. In diagnosis multiple myeloma, we can do several tests that may help, including biopsy of tumor cell or bone marrow cell, pancytopenia checker, and the existence of roll-up formation. The treatment of myeloma was divided into 2, which is non-intensive and intensive. The medicine generally including a chemotherapy medicine, a steroid medicine, either thalidomide, but besides of the treatment, survival rate of patients with multiple myeloma depends on the disease stages.